now going to listen to Raymond Yip from Hong Kong. And I'd like to thank him for having traveled such a long way from Hong Kong to Les Arcs.
Thank you for the GECO invitation to give this talk on my experience using the cervical and lumbar TDR, and how I found the viscoelastic concept very interesting as compared to the previous mechanical prosthesis. So I work in Hong Kong. This is the hospital I do most of my surgeries at. It's over 100 years old, and it's on a peninsula, so you have 270 degrees sea views. So we know that lumbar lordosis is very important, and 2/3 occurs at the lower lumbar spine. And this is very important to reconstruct when we're often dealing with disease at the lower spinal segments. The lumbar lordosis changes with posture, and if we fuse the spine, we destroy this mobility of the spine. So it's interesting that that the attempts at trying to preserve mobility of the spine. So when you're young, you see that the range of motion of the lumbar spine is approximately 40 degrees. And when you get older, it's about 25 degrees, but there's still significant motion in the lumbar spine when you're sitting and standing, and it changes. So this is a surgery I did, and this almost convinced me that I'm doing something wrong. 3-4-4-5 disc degeneration with severe spinal stenosis, requiring decompression and fusion of these two discs. And this surgery was done in May 2014. He comes back 3 years later, only 3 years, and the fusion has done well. However, he's developed ASD, adjacent segment degeneration, proximally and distally, so above and below the fusion. There's new DDD. If you go back, you look at the discs before, above and below, they were quite normal, and this is only in the space of 3 years. So is this a natural phenomenon, or is it actually provoked by the fusion? And the fusion surgeons will tell you this is not the case. We don't have adjacent segment disease, but I believe otherwise. So the interest in lumbar disc replacement came about because of the need to try and preserve mobility of the spine. Lumbar disc pressure is interesting. When we're standing, it's roughly 100 kilos here. And when you're sitting, it's about 150 to 200, depending on how you sit. And things get more interesting when you start lifting 15 to 20 kilos. So lifting 15, 20 kilos is about 200 kg load on the spine and the discs. When you bend and lift, it's about 500 kilo. And this is only lifting 15 to 20 kilos. So if you go to the gym and lift something heavier, I don't have the data, but I'm sure it's a lot higher than this. So the lumbar discs are subject to vastly increased pressures compared to the cervical spine. This is the cervical loading. So cervical spine has an easier time. So we're only seeing about 5 kilos with a neutral head position, going up to about 25 kilos or 60 pounds when you angulate your head downwards by about 60 degrees. So cervical disc replacements have done very well with the mechanical type prosthesis. However, with the mechanical type prosthesis, I was having problems with mine, so I stopped using them. So head forward posture again, not very heavy compared to lumbar. Disc motion, there's elastic recoil of the disc, so the mechanical prosthesis cannot replicate this. There's no elastic recoil, so we're not seeing the sort of spring back phenomenon that the viscoelastic can offer. There's compression, so it acts like a shock absorber rather than just a motion segment. And there is spinal loading, so we know that this is often taught that 80% of the load of the spine goes through the anterior column and 20% goes through the posterior column. So my experience with lumbar TDR, 2006 Charité and ProDiscal, which I did for about 2 years and I stopped, worried about problems with these implants and revision because there were reports of facet joint problems, of implants core expulsion. and went back to doing ALIFs and other forms of lumbar fusion. And was introduced to the viscoelastic TDR in 2017, and I've been using it since, well, actually 2016, and been using it since 2017, and I've had very good results with the viscoelastic TDR. So ball and socket designs, little or no compressibility, no elastic recoil, rely on facet joint integrity. This is important. The facet joint issues may come about because of they're probably more reported facet joint issues with mechanical prosthesis than with viscoelastic, and obviously concerns with longevity. So we know that total knee or total hip replacement often can last up to about 20 years, but beyond that, no one really knows. And the mechanical type prosthesis possibly also. Some of the earlier failures of the mechanical prosthesis, this is at 6 years. This is a fracture caused by the keel on this device. And basically with mechanical TDR, you're balancing ball bearings. So you're putting multi-level. It can be very difficult to achieve good soft tissue balance, and you have to line up the cores perfectly. And it's quite unforgiving if you don't line them up, and you can develop a scoliosis de novo. So the viscoelastic concept, silent block shock absorber, which the others do not have, feature supposedly no mechanical wear, and there's the elastic recoil, so it'll spring back. And they've designed this device to be very similar to the human disc, so if you look at the parameters, very similar. In fact, it's slightly more flexible than human disc. When you hold it in your hand, it appears to be quite stiff, but actually it's actually more mobile than the human disc. This is another viscoelastic implant, so not all the same. This one may be too stiff. You see there's very little motion after implantation. There is some, but it may be too stiff. It may be that if the implant is too stiff, there's a lot more force concentrated on the end plate, so the end plate bonding may be not as good as mechanical type prosthesis, which is probably too loose. So we don't actually see any problems with the mechanical interface between the bone and the implant within the mechanical type prosthesis. It's less common problems. This may be acting more like a fusion cage. So there may be problems trying to get the fusion of the end plate to the bone. Another viscoelastic type implant, which they've designed to be like the human disc, but that may not be a good thing. So the human disc may be flawed, because we're seeing a lot of disc degeneration. So this is some video. Can we run the video, please? So that's showing compression. And this next slide is interesting. This is a disc design that was designed to be like the human disc. However, if you look at the fibers here, you see they're actually moving. And this is possibly going to fray. So like a rope that's going over a pulley. If you do that over several million cycles or several hundreds of thousands of cycles, you may actually see these fibers actually fatigue. And I think that may be the mode of failure of this device. And then the core will probably, just fall out. So this design, interesting. They designed it to be like the human disc. That's what they claimed. But we know that the human disc can degenerate. So is this a good idea or not? This is some failures of this device. So you see this is directly after implantation and by 6 months. So this is June and this is December. It's already starting to displace and malalign. And there are some more examples of this. So this is just a few months after implantation. So the core appears to be displacing asymmetrically. And it's developing a spondylolisthesis of the implant. Another one, directly post-operatively and a short time afterwards. So I this implant I'm a little bit worried about. So copying the human disc may not be a good idea. And this is my youngest patient for a lumbar TDR, 13-year-old. Back pain for 1 year and developing leg pain for 6 months. And you can see that the L45 disc has herniated, causing compression of the left L5 nerve root here, and the L5-S1 likewise as well. So she's got compression of L5 and S1 traversing nerve roots, and a double lumbar disc herniation at the age of 13. So do we simply do a microdiscectomy, which was what was offered to this patient initially, or should we do something else? After we look at her standing x-rays, you see there's no lumbar lordosis. So just a simple decompression may not suffice. She's actually got close to 0, 5 degrees of lumbar lordosis only, with a PILL mismatch and a scoliosis. So I'm not sure if this scoliosis was caused by the hernia or otherwise. But anyway, she decided that she needed something done. So she had 2 lumbar disc replacements, went home the next day and only needed pain medication for 2 days. And this is her follow-up at 2 weeks. So we see restoration of both the scoliosis and the lumbar lordosis. So this was a very amazing result. And this is a 13-year-old. Another patient with back pain for 13 years, severe left leg pain. So this would be, and he started off with a 5-1 disc degeneration. Now he has 4-5. So that stopped moving. He's losing his lumbar lordosis, and you can see 3-level disc disease already. This is the MRI. So he's developed, I don't know how many disc herniations here, maybe 1, 2, 3, triple disc herniation at the 4-5, and it's foraminal. So it's very difficult to remove from a conventional microdiscectomy. He's got small facet joints. So would be hard to preserve this to try and remove that. Discectomy from the front and post-operative. Another patient with a failed decompression, PILL mismatch, 2-level disc disease, with basically a failing L45 disc. You can't really do a microdiscectomy for this because it's circumferential. Again, removal of the disc from the front. And so these are my early cases. This is my first and second case. 2 lumbar TDRs. And this is him the next day. Can you run the video, please? So he was in a wheelchair before, which you see here. And this is him 1 day after surgery. So it doesn't appear to be any discomfort. And we see restoration of the lumbar lordosis, which is important. So compared to preoperatively, he's gained 24 degrees of lumbar lordosis. Some of this may be due to pain, but the posture has changed significantly also. And there's good motion preservation on his flexion extension. So we're seeing about 8 to 9, between 8 and 10 degrees per implant with these patients. This is a hybrid surgery. So initially I wanted to do a 3-level fusion for him, but he refused to have a fusion because I did a cervical disc replacement for him in the past, and he was very happy with that, so he didn't like the idea of a fusion. So in the end we achieved a compromise, and it was a hybrid construct. So the L45 is quite tilted, so I fused that and put a disc replacement above and below, but he's got 3-level disc disease. Previous decompression at 4-5. And he had a 3-level. This one I would have been wary of in the past with a mechanical prosthesis because of this high sacral slope. So it looked something like that. But slightly tilted, but did a CT scan at roughly 6 months and everything had fused up. So this is the CT. and everything's fused up, so all stable. Revision, this is one of my revisions. So this one, patient came in for discogenic low back pain. And the implant, this is my first migration. It migrated, so came out. And it was actually fused in this position, but I didn't like it, and it wouldn't be working as a disc replacement. It's more like a fusion because the implant cannot move in this position. So revised to a, and this is what I do to prevent back out now. Subsidence, another patient with 2-level disc disease and initial post-op. So possibly oversized, and he subsided at first follow-up. So I did a vertebroplasty and found out he has quite a low bone density, so equivalent to a 120-year-old. Failed TDR. This one is a patient who has HIV. He has a previous laminoplasty and a previous 3-level lumbar fusion from L2 to L5. This is quite interesting. So this is the first core failure of this type of viscoelastic implant. So he developed adjacent segment disease at 5-1 and had a disc replacement there. So laminoplasty in the past with 3-level fusion here and developing foraminal stenosis at the bottom. So this is, before surgery and after surgery. So this is after the 3-level lumbar fusion, and then this level broke down. So he developed foraminal stenosis at the L5S1 because the disc collapsed there. So new problem with the ASD here. And a TDR was put in. He developed a complication from the HIV, he developed AML, he developed leukemia, and passed out driving on the way to the hospital. So my hospital was right on the top of the hill, and he drove off into the mountain path, into the trees below, and he injured his neck and his back. His back wasn't too bad, but it was mainly neck pain afterwards. So he has a C2 fracture. So the laminoplasty has not done anything, but he fractured his C2. So it's like a pars fracture and a laminar fracture of C2. It's deemed to be stable, so it's managed conservatively. And it healed at 10 months. And then developed back pain. And this is the core and the implant, and developed back pain. So the MRI, because of the back pain, we did an MRI, and there was an epidural mass. And I don't know what that was. So, and the implant appeared to be eroding into the bone. So because of this, he was offered a revision of the L5S1. That's the vein. So it was revised to an ALIF. And this is what was found, a broken implant. This is, the silicon core had disappeared, and all was left was a PCU, and it's also yellowed. So this has been sent back to the company for analysis, and I still haven't heard back yet. But as far as I know, it's one of the first recorded cases of this implant core failure in 15 years. Access complications. So apart from the complications, immediate post-operative complications, there's also possibly the access is challenging for some patients. This patient has a 3-level disc disease with degenerative kyphoscoliosis and mild sagittal imbalance. 3-level disc disease with 2-level spondylolisthesis. In front of the L4-5, there's a lot of blood vessels. So you can see that disc is quite difficult, and blood vessels are on the side. So possibly lumbar plexus is here. So doing a lateral or anterior to psoas approach, possibly difficult. with this sort of scenario. So I opted to do an anterior approach. It's mainly the 4-5. So I had a 3-level A-lift. This is just showing the approach complications. And there was a retraction injury of the left common iliac vein, posterior wall tear during the surgery. Can we run the video, please? This. So everything seems okay until you retract gently on the vessel, and there's a big hole at the back. So I felt it was unsafe to leave alone, so I ended up having to try and repair. So I ended up repairing it. And the video, please. This is a posterior wall tear of the iliac vein. So we do encounter these problems. Okay, so in summary, my thoughts, TDR design is extremely important. We had the first generation mechanical prosthesis, now we have the viscoelastic. There are problems with initial immediate stability, so you may see implant migration initially. I think this is, a lot of it is to do with how you prepare the end plate. So it's essential that all of the disc is removed. We talked yesterday about a possible case where some of the end plate cartilage had been left behind, and that just acts like butter. So the implant will just slide out. And long-term fixation, so hydroxyapatite coating is important. The design of the core, if it's too loose, there may be possible core wear and displacement. If it's too rigid, there may be too much stress on the end plates and the problem of fixation of the TDR to the bone, so end plate fixation issues. Placed next to a long fusion will magnify forces on the TDR implant, so the failure of my surgery is possibly because the TDR was not designed to do that much work. So putting it between two big long lever arms probably would cause problems. And there's also greater stress at junctional placement, so at the lumbosacral junction, so L5S1, always is a problem. If you're trying to fuse L5S1 or if you're trying to do a disc replacement at 5-1, there are the greatest forces are at that junction. Okay, thank you.
Thank you again, Dr. Yip, for presenting us your wonderful experience about viscoelastic prosthesis. I'm not a spine surgeon, but there is in the room many well-known spine surgeons, and they have probably some question for you. Jean-Yves, peut-être?
Vous le savez. Spine surgery is changing a lot. It's no longer 2 or 3 year feedback follow-up. I'm sorry, we've got 10, 15-year follow-up in some cases, done by very experienced surgeons. And what's absolutely fascinating with our colleague is that he used mechanical discs, and then gradually he went to A-lift and came back to disc implants. So this personal experience is absolutely relevant and shows that we are now able to treat patients who could not be treated in the past. It may be difficult to understand. However, you need to know if you're a hip and knee surgeon that there are now new solutions that have got long follow-up.
When we start with the disc replacement surgery, it was now quite 20 years ago, and it was for us a new type of surgery. The patient was completely different. It was a new specialty. It was not what we did before. It was a new way. And with we spent many times with the mechanical prosthesis, and now with the viscoelastic implant, It's different. It's something different, and we have to go further to know exactly what we can do with that. And what I say is, with the mechanical processes, with the ProDisc, we try to do many things, and we go to the limits of the processes. And now with the viscoelastic processes, we have to go also where we can go to the limit to see if we do more or not.